turn this on. If we can work our way to our seats, we'll start. There are some seats up front. I see some, unless you prefer standing, it's been a long week, but okay. Namaste. My name is Naveen Rao. I'm the Senior Vice President for Health at Rockefeller Foundation. And on behalf of all my colleagues at Rockefeller Foundation and my partners and friends at UNICEF, welcome. You could have been anywhere this evening. There are enough events happening in New York City around UNGA, but you chose to be here. We respect that, we honor that, and we hope to make it worth your while. As I look around, I see representation from multiple sectors sitting here. I see academia, I see governments, ministries of health, I see finance, I see tech, I see civil society, founders, and truly gladdens my heart because it takes all of us to come together to tackle the problems we hope to tackle. I'd like to now turn it over to who we call our doer-in-chief, our president, J.Shah of the Rockefeller Foundation.
Good evening. How are you? Thank you, Naveen, for your extraordinary leadership and convincing everyone to come out here. And thank you to your team. Many of you may not know our full health team. Some of our members are new, but Nana, Manisha, David, and the rest of the crew, thank you so much for your hard work and your leadership. We do gather tonight at a pivotal time in the fight to achieve health for all. 4 years ago, how many of you were here 4 years ago at the UNGA event? Yeah, good, there you go. So you know. 4 years ago, and frankly for many years before that, we came together as a global community to set goals that represented the future we wanted for our children, where no child dies of simple diseases, where every mother survives childbirth, where all of humanity has an equal chance at a full and hopeful life. Yet on multiple counts, the arc of progress has plateaued. Despite overall gains in reducing deaths for children under the age of 5, the needle is moving much slower for babies surviving their first month of life, and the same is true for mothers. Across sub-Saharan Africa, progress is stagnating, while in some places, including here in the United States of America, maternal deaths are actually on the rise. So here's the bottom line. We are not on the path we hoped to be on 4 years ago. And it's not because we lack know-how. It's because we have not done enough to extend the knowledge and resources we have to the front lines of health in the very poorest communities. But now we have a chance to change that. In the last 5 to 7 years, we've seen incredible advances in data science and other technologies that can help us achieve our goals. And we're betting that deploying these tools to frontline healthcare workers, putting data-driven insights in the hands of a global community health workforce that is more than 5 million people strong, will in fact be transformative. I saw the power and promise of data for health during the 2014 Ebola crisis in West Africa when I was in a different role. At first, we were struggling. Most community health workers on the front line of that response were, in fact, flying blind. But once we started to get transparent, location-specific, real-time data on where someone had perished from Ebola, and who their relatives and other contacts were, we could target prevention and response efforts much more precisely. The data really do tell the story. We stopped the epidemic more quickly and more effectively than anyone thought possible. It was a powerful example of how investing in the health of those least fortunate helps us all. And it convinced me that if we're going to achieve our goals in global health, we need to use these data tools more broadly to make public health efforts much more precise. That's why we are launching the Rockefeller Foundation's new Precision Public Health Initiative, which will take this concept to scale for high-risk families in vulnerable communities around the world. Together with our amazing partners, we're committing $100 million to this initiative with the goal of saving at least 6 million lives in 10 countries by 2030. We're starting in Uganda and India, which combined have more than 2 million community health workers. These individuals spend their days going door to door. This initiative will seek to empower them with better data and predictive analytics so they can precisely target proven community health interventions to those families with the greatest needs. Doing so will help save millions of lives. And doing so will also harness the frontiers of science and technology to build a more equitable world. Think about it. Less than 5 minutes away is the Apple Store Grand Central, where you can buy, if you have enough money, a watch with an ECG monitor that assesses your heartbeat and tells you if something is wrong. And that's just one example of how data, science, and technology are revolutionizing human health. But here's the problem. When it comes to data science and technology in health, most of the brightest minds, most of the largest investments, and many of the best innovations tend to come from and be designed for the parts of the world that are healthiest and wealthiest. The result is health for some, not health for all. And it's only deepening the extraordinary inequalities in our world today. Almost everyone else is being left out and left behind, like this mother in Burundi, Mama Fides, and her 11-month-old son, who has a high fever and anemia caused by severe malaria. So at the Rockefeller Foundation, we've been asking a fundamental question. As data science and technology increasingly make it possible to live longer, healthier, and more prosperous lives, will this happen equitably? Will it lift up all of humanity? Or will more and more be gained by fewer and fewer people? You all know the truth. Right now we're facing a future where some people who have money and access to cutting-edge innovations are likely to live to and beyond 100 years of age. While on the same planet, a baby girl born in Chad, born into poverty, is 55 times more likely to die as a child. A number so high, it's morally outrageous. Tomorrow, approximately 14,000 children worldwide will suffer a similar fate. Most will die from preventable, treatable causes of disease, such as malaria, pneumonia, diarrheal dehydration. Even though we have simple, proven primary care interventions, like treated bed nets, vaccines, and oral rehydration solutions, that we know can save these lives, and that frontline health workers can deliver effectively if given the chance and the tools. Precision public health can bridge this gap. Let me show you. We've had these kinds of maps for years showing where child mortality is highest. Today, we can even model it down to a 5-kilometer resolution, which is extraordinary progress. This is great for high-level reporting, or if you're managing resources at a global, regional, or national level. But if you're a frontline health worker trying to save lives door to door in a community, you need something very different. Put yourself in the shoes of a frontline health worker like Deborah here on the left. You work countless hours trying to save the lives of mothers and children, often your very friends and neighbors. You've watched babies die in their mother's arms. You've had people survive one day but perish the next because there wasn't enough medication or supplies on hand. It's easy in that context to feel powerless. And you can't solve what you can't see. Top-down population estimates of health risk, like the ones I just showed you, really don't help you very much. You need data that is much, much more precise. The good news is that this capability is finally emerging. I'm glad Uganda's health minister, Dr. Jane Aceng, is here with us today. Thank you for your partnership and commitment to innovation. Today, the Ugandan government and its partners have the ability to create detailed data sets with information gathered by frontline health workers. If you match it with location data, you can see where women and children are dying and why precisely at the household level. And if you integrate non-health data, you can take this to a whole new level. In the health world, we call these social determinants of health. Things like income, infrastructure, electricity, and proximity to health clinics. When we plug in those data sets, showing the main power grid and the nearest clinics, we believe we can generate predictive insights that let us target health risks with even more pinpoint accuracy. It means we can act with more precision and more efficiency than ever before. Imagine if a frontline health worker was empowered with the right information at her fingertips that can help her make the right decisions. She could pull out her phone or tablet and see in real time who, when, and where the health risks are greatest in her community and what it's coming from, a disease outbreak, a home birth, or an impending flood. Then she can stock up on supplies, arrive early, and provide the care, resources, knowledge, and connectivity that can help save lives. That's the power of precision public health. And not only is it key to unlocking health for all, we believe it will help save at least 6 million lives between now and 2030 in 10 countries, starting with India and Uganda. Over time, precision public health can be a strategy to address other major health challenges, from chronic diseases like diabetes, to mental health, to preventing the next pandemic. And because we all believe in data, otherwise we wouldn't be here today, we will, of course, measure our progress, starting with how many frontline health workers are able to use these analytic insights and whether it's made them more effective at doing their job. Tonight, you'll hear from many of our extraordinary partners, including Henrietta Fore of UNICEF, an innovative and demanding leader who is absolutely on the frontiers of innovation in this space. You'll hear from Dr. Tedros from the World Health Organization, who understands community health perhaps better than any other former health minister on the planet. You'll hear from Dr. Seth Berkley, a former Rockefeller alum, but now the leader of Gavi, who is putting resources and detailed measurement in practice all around the world. You'll hear from Peter Sands of the Global Fund, who believes in data analytics empowering those who are trying to reach the most vulnerable. And you'll hear from Dr. Mohamed Pate from the Global Financing Facility supported by and hosted by the World Bank. It's rare for so many different and diverse global health organizations to stand on stage together and join hands for this common purpose and for this common goal. Forging committed partnerships has long been a hallmark of the Rockefeller Foundation, and we're proud to continue that tradition with you all today. We'll also hear tonight from private sector technology companies whose capabilities and resources could really help accelerate this work even more. This initiative will be the central focus of Rockefeller's health work over the next decade. having shaped the field of modern public health more than 106 years ago, we're now attempting to bring public health into this century together with our extremely innovative and courageous partners. It's a cornerstone of our commitment at the Foundation in this new era to make sure innovation empowers all of humanity to rise. If you remember nothing else tonight, please remember these three women: a frontline health worker, a mother, actually a grandmother, and a baby girl. Because the actions we take today on behalf of them speak volumes about our values. Thank you all for being here. Some of us together have been working on this task for decades. But all of us are here in this room because we're committed to a very simple idea: that we are all connected to each other and should work together to extend the reach of human dignity to every single person on this planet. I know this week in this town we've heard some different visions of the future. One in particular that says our purpose should be to look out only for ourselves and elevate our differences over our common aspirations. Against the backdrop of that competing vision, I know those of us in the room here tonight will look back on this work together and take pride in how our actions made clear where we stood at this moment. Because they also make clear what we value: a health worker's desire to serve her community, a mother's love, a child's future. That is what we're fighting for, who we're fighting for, and why I hope all of you will join us and our partners in this mission forward. Thank you.
Thank you, Raj. Wow, for laying out that vision so crisply. I would like to now call on stage two prominent voices in health, and we're tongue-in-cheek calling it Wireside Chat. There's no fireside here, so decided to call it that appropriately. The first is a leader who has experience in multiple sectors, a prominent leader in health, in development, in rights, Henrietta Fore, Executive Director of UNICEF. And I'd like to also invite on stage senior writer from Time magazine, Alice Park, who has written for the last 25 years, a journalist, an author, and who's going to be a moderator for the evening. And I actually turn it over to her for the rest of the evening. Thank you very much, Alice.
Thank you. It's a pleasure to be here, and I am truly honored to be moderating this panel with Raj and Henrietta. It's been a very exciting week here at UNGA. Just Monday, we had our first ever high-level summit asking for universal health care. I wanted to ask both of you how data fits into that. How does data help us achieve that?
Well, universal health care is still a dream for all of us. So one of the ways is what Raj was talking about, which is that if you think about partnerships that can have precision public health, so...
Is your microphone not on?
Well, or maybe it needs turning on. Technology. Excellent. All right. So universal health coverage is still a dream. But what Raj was just talking about is precision public health. And if we could get to that as a partnership, it would make a big difference, that you could be out in rural areas, you could be in the slums, but that you could get to the right person at the right time with the right remedies. We've also talked about something else, which is a partnership for intelligent community health. And I think that's going to be the wave of the future. And you've done quite a bit of reporting about what lies in the future. But I can see from our programs that what you were talking about, Raj, about being able to be predictive, whether it's in Ebola or whether it is when we have a crisis coming. I was in Beira in Mozambique the week after the first floods hit. I mean, if we could tell when a big weather system like that was coming through and where it might hit, it would mean that our supply chains could move pharmaceuticals and products and supplies to the right place ahead of the storms, and that would make a big difference. We also have something called Rapid Pro that a number of people have used that allows you to keep data. So in Indonesia, you can keep the vaccinations for millions of children. If you can do that, if they then start moving, they're on the move to another location or another place, and they're in the middle of a vaccination a remedy, what happens is that they're empowered. It means that health follows them. It isn't that they have to wait for it to come to them. It will change people's lives. It will change all of our lives. So universal health coverage has to mean that there will be a digital health component, that it will be very strong, very robust, and that's what we'll hope for today.
And Raj, you talked about how, you mentioned the latest thing that's getting everyone excited, the new iPhone. But I think traditionally we often do, when we think of technology and when we think of data, it can be either democratizing or very dividing, and it can really set the stage for a situation of have and have-nots. How do you envision using technology in a way that will really increase access and in a practical way accomplish what Henrietta was just describing?
Well, the fundamental answer to that is in partnership with operating entities that focus on equity, and that are on the front lines of addressing inequity. And UNICEF is perhaps the most significant global institution, supported by so many of our other partners here today, actually doing that. And Henrietta has brought both a commitment to innovation, so that the UNICEF teams, country after country, are supporting health ministries by bringing innovation, bringing technology, but it's all with a lens of achieving equity, of finding out who's not. I was actually in a room today with UNICEF and a bunch of our technology partners and ministry representatives from Uganda, and they were sitting there and they're saying, well, how do you create a technology product and a data output that advances equity? And I guarantee you, with all due respect to Apple, I love Apple, buy all their products whenever they come out, basically. Like, they're not probably sitting back there and saying, okay, how are we going to advance equity when they're designing that, because it's not their job in that setting. So we really need institutions like UNICEF at the forefront of this effort. We need Gavi and the Global Fund and the Bank, which are the extraordinary engines of innovation and investment in global health, to align and lead as they are doing. And for us, it's really special to be part of a partnership that is fundamentally about equity, with all of this technology backing it up.
6 million lives, 10 countries by 2030. That's 11 years, which in the global health scheme of things is really not that long a time period. What are the top priorities? What do you think are the low-hanging fruit for being able to, go in and take the technology or the resources that we have right now to make the most impact?
Not being the doctor, I'm going to say pneumonia, because we lose so many newborn children to pneumonia, that if we could solve that, that would be tremendous.
Yeah, I can agree with that, and also say I think the ability to just micro-target the high-risk household, the high-risk woman, the high-risk child who is not otherwise getting special outreach, that's the big breakthrough. Because the community health workers that, there are 5 million around the world. In Uganda, and India alone, more than 2 million. Many of them have the tools to address to support community case management of pneumonia, or to connect someone with malaria to a primary care facility, or to reach a woman who's going to be a high-risk pregnancy and give them a voucher and support their access to an assisted childbirth in a facility. The issue is, are we reaching the families that are still suffering death events from simple things? And you know, you just look at map after map. I thought the Gates team's goalkeepers report makes this point exceptionally well. That where we have effective outreach, we're actually driving the numbers down aggressively. Where we don't have outreach, we're failing. And we don't have the capacity to have the outreach absolutely everywhere. So using the limited capacity we have on the highest risk and therefore highest value patients, clients, however you want to describe it, is going to be what changes the numbers and achieves the goals.
Could I add one thing
Absolutely.
to that? So Raj mentioned all the partners who are in this room. And one of the things that you see whenever you're out in the field is that we need to train all the community workers. They're the ones who are really doing this. So if we're going to save 6 million lives in the next 10 years, it's going to have to be those people on the ground who are really well trained, and they're in the countries, and they're the most important. The other thing that we could do to help them is if we can get the technology so that we can do diagnostics. That will make a big difference, because sometimes you're out there as a community health worker and you really don't know what's wrong. But if digital health could help you diagnose, we could help in the last picture where we have the grandmother, the baby, and the community health worker. We could help them on the ground.
That's a great point, and I know that Naveen and I have talked about this, and he has a great analogy which I think works wonderfully here, where he says, you know, think about how we think about our weather now, right? We have wonderful algorithms. We're able to predict when it will rain, what the humidity will be, what the temperature will be, and we can do that because we have data points in millions, perhaps trillions of different places, and they're collecting data constantly. Is that a good model for how we might approach, you know, being able to improve health outcomes around the world?
Well, if Naveen said it, it must be. It must be right. I got a room with 300 of his best friends. I got it. I think what we see is this huge discrepancy between all of this investment going in to make all of our lives, you know, a bit more efficient, a bit better, and then saying, can we use those tools, and can we use those data layers, and can we use some of the analytic tools that have really only become real in the last 5 years to apply that data science capability to save extremely vulnerable people. And I think that bridging that inequity is what this is ultimately all about. So as the technology gets better and better, yeah, this is going to get better and better and better. Our goal has to be constantly saying, are we using these tools to save the lives of those who are most vulnerable and those who are least served by today's global healthcare system?
When you look at achieving this goal, how much of our existing technology and our existing resources, infrastructure, do you think are going to be useful in achieving that? And how much do you think we still need to develop? Are there technologies that you are hoping to have in the next 2, 3, 5 years that you hope could accelerate reaching that goal?
Well, I'll let Henrietta follow this. I think we have, first, this only works on the basis of UNICEF, Gavi, Global Fund, and most importantly, health ministries that are well-resourced and able to go serve people. So this is a kind of an Intel Inside kind of strategy to optimize the efficiency of a system that needs to be well-resourced and prioritized. So we need to have a successful global fund replenishment. We have to continue to invest in Gavi. UNICEF should be supported by every government at a much higher level. If you actually saw the level of innovation and rigor around data and equity that Henrietta has brought all the way down, up and down the system, these are gems that deserve much, much, much more public investment, which is why I wanted to point out that this is a results-oriented, practical way to use technology to save lives. It's complete opposite of what we're hearing about countries should retreat from achieving global common aspirations. In fact, now is the time to invest more, not less, in these great institutions.
So I'll toss in there that I think we also need to consolidate. So sometimes we're off running on our own great idea and we forgot to bring our best 10 friends along with us. And if we would do that, that would certainly help our work. The other thing that would help is, you know, when you're out in the field and you see the community health workers and the nurses, they have belts on them with all these objects, and they're all the ones that we give them. Supply chain replenishment, this is for temperature, but they have so many of them. We've got to connect. So as a team, as a partnership, Raj has brought us all together. So if we could connect and if we could consolidate, I think we'd really get there. I think we could save all 6 million lives.
I think that was just a call to action, right, from Henrietta. What partnerships do you see are lacking at the moment, you know, or need strengthening when you look at that collaboration, when you say we need to connect more? Where, if you had your wish list of being able to say, let's put, you know, A and B together, what would you do?
So for me, private sector. Some of the things that happen when you're in government or the United Nations or in a foundation is you're not up on all of the technologies that the private sector is creating. They're racing ahead of us in all sorts of areas, and sometimes we don't know it because we're so busy looking after the most recent emergency. So if we could connect private sector innovations and technologies and ideas and systems onto the platforms, we can do this as a group, but we've got to get the private sector in addition to all the groups that Raj mentioned.
Raj, yourself too, your comments on that?
Well, I agree with that, and I'd add that the community health workers themselves, like they're, you know, Henrietta has walked in their shoes in so many different places, as have, I suspect, many of you in this room, who I have the benefit of having learned from over time. And, you know, they have a commitment. I've always wondered, because so many of them are not even paid a proper wage. They just have a commitment that is extraordinary, and they have instincts about where to go. And if the mindset of this collective partnership is we're serving them with products, technologies, data outputs that help make their work better, more effective, more rewarding, and more successful. Like if that is a constant focus, then we'll be successful at getting that integration that Henrietta is calling for.
Would another way to sort of think more in an umbrella term about this in order to improve collaboration and to, you know, really kind of prioritize areas where we could make the most difference most efficiently be to think about how we define health versus health care? You know, I think so often the two are conflated and they are very different. Can each of you talk about what health versus health care means to you?
Well, look, I'll just say, I think one of the tragedies of health is perpetrated, I know I'm going to get myself in trouble, is perpetrated by doctors, I'm one, I used to be, and others who've made everything about medical professionalism, right? Like most of the community health workers I've had the good fortune of interacting with have not actually benefited from a lot of medical training at all. And yet their ability to be effective points of connection between high-risk, vulnerable, low-income people in their communities and the services and technologies they need to save lives is the difference between achieving the Sustainable Development Goals or simply walking away. So the more we honor the fact that public health is a discipline, that precision public health relies upon a workforce of people who can make extraordinary impacts and deserve the respect that we might offer a doctor or a trained nurse, I think the better off we'll be at expanding the definition of health.
Henrietta, your thoughts?
Well, for us, since we live with children and young people, health is usually an ecosystem. Are they nourished well enough? Sometimes a baby is born so low in weight that it's very hard. They're struggling in those first few years. And if they don't get enough nutrition, then if they're under 5, if they may be stunted. I mean, it's an ecosystem, so there has to be clean water, there has to be sanitation, there has to be food, there has to be education and stimulation, and then there will be health. But as I have traveled around in the world, when I was listening to Raj, it reminded me, I was in Yemen, in Sana'a, in the main hospital, and we were there, and families were just streaming in. You know, Yemen has cholera endemic, and so many of the families had babies with cholera, and they were malnourished. The health workers in that hospital had not been paid in 2 years, but they had the calling. So people who work in health, doctors, nurses, and healthcare workers, they were coming in because they said, I can see I'm needed, I have the skills, I will keep showing up day after day. And for 2 years they were doing this. So, I mean, it's that kind of a commitment that will drive health and health care in our world. But just from a personal note for health care, I want it to come into my home. I want healthcare to come digitally into my home. I want it to find me, diagnose me, and then bring me whatever remedy I need. So if we could do that, that would be great.
I'm with you there. I'm with you there. And on that challenge, I want to thank both Henrietta and Raj for your time.
Thanks, man.
And you're not done with me yet. It is now my privilege to introduce our highlight of the evening, our remarkable panel, which we are pulling together here today just for you. I think we'll have a wonderful discussion. I'd like to start by inviting the Honorable Dr. Jane Aceng, Minister of Health from Uganda. Dr. Mohammed Pate, Director of Global Financing Facility and Global Director of Health, Nutrition, and Population at the World Bank. Geralyn Miller, Director of Microsoft Genomics for AI and Research. Dr. Seth Berkley from Gavi. And Hema Buddharaju from Facebook. And last but not least, Mr. Peter Sands from the Global Fund. And actually, I'm going to do a little bit of musical chairs here, Mr. Sands. I'm going to ask you to be over there since I understand you may have to leave a little bit early. Juggling a lot of events this week, as you can imagine. Dr. Aceng, yeah, if we could just, or actually we could all just move down. Think one, that'll be the easiest. Yes.
Wow, it's complicated.
It's complicated, sorry about that. There should be, right? There should be, and I think I stole someone's microphone here. Can I go there?
I don't have a mic, but I can yell or sing.
Sit right here.
Okay.
Does everyone have a mic? Thank you all. I really appreciate your taking the time to be here. We have a big panel, so I want to get started right away. I wanted to ask and start this discussion off by asking each of you to think of one word that would describe, from your area of expertise, the biggest challenge in making data make a difference in health outcomes. Biggest hurdle in your mind. We'll do like a quick rundown down the panel. Hema?
Access.
Okay, Seth?
Decision making.
Geralyn?
Social engineering.
Okay.
Learning.
Mohammed. Learning?
Yes.
Okay.
Use of data.
Okay. And Peter?
It's too old.
Okay. All right. Fair enough. Let's start, Peter, with you down there. What do you mean by that?
Well, I came from the financial services industry, and I ran a global bank, and what day is it today? Wednesday? Yes?
Yes, Wednesday.
Wednesday. By Wednesday evening, I would have a pretty good idea of how much money we had made globally. We operated in 70 countries on Tuesday. It wouldn't be perfect, but it would give me enough information that I could take actions on Thursday to correct things that were problematic on Tuesday. Now, I kind of think of fighting a disease like malaria globally as like being asked to fly from New York to LA, but with one little condition: you can only look out of the back window. And also, it's even worse than that. By the time you've got to the Rockies, you're probably looking at Ohio, which is not terribly helpful. And if you really focus on it, you find that actually the map of Ohio is not very detailed, and then somebody tells you that the roads are estimated. Right, they're not actually the roads, they're estimated. And I think this is a real problem. And this is a serious point. I mean, we have a World Malaria Report, which will come out in November of this year, which will tell us what happened in 2018. Now, the intrinsic volatility of malaria is that malaria can go up by 20, 30% in a month in a place. So knowing what happened in 2018 is kind of interesting, but in any material sense, when you think about decision making, actually really isn't very helpful. So one of the, this is not just about, there's a lot of things which are about money and the actual technology and the software and all this. It's also about mindset and ambition and things. We should expect to have data that is fresh enough that allows us to make decision making in a much more real-time basis than we have, because that will lead to better decisions and more responsiveness.
Dr. Aceng, I'd like to ask you to address that. In Uganda, is that a big challenge for you as well? Do you agree with Peter that the data is not, the turnaround, in other words, isn't fast enough?
Absolutely, and Peter has said something that is very interesting, but that also affects public health grossly. Because if you're receiving data of 2018 in 2019, and by the way, this is September 2019, it's no longer useful. Death does not wait. People need health care, and they need it immediately. They won't wait for 1 year, 2 years, or even 1 month. When you need data, you need it now for you to take the right decision and act. And if we are talking about, for example, Ebola, if you're going to wait for 1 year, then you will have the same situation that happened in West Africa, and that's not useful. You need information concerning Ebola within 1 to 4 hours for you to act and make sure that you control the outbreak. And so if we are talking about data that is useful for decision making, it has to be real-time data.
And I will get to you, Dr. Pate, but I just want to jump onto what Dr. Aceng just said, and we have here representatives from Facebook and Microsoft. So this is a technology question. Hema, I'd like to start with you. Realistic problem, criticism, and are there solutions to can we solve it?
Sure. Raj actually used this example, so I'm going to say this. Imagine if the humanitarian agencies had access to not just a county level or a province level set of demographic information that's outdated, but what if you had the exact number of women and children under 5 who are in that village so that you can deploy vaccines at that moment. What if you had access? Imagine a world if you had access to knowing where people are moving from one place to the other place, and you could predict the movement of cholera along with them. And I'm going to actually tell you, you don't have to imagine. We have these tools today. And Facebook has introduced disease prevention maps, and part of this data set is to help you look at where is the population presence, what is their movement looking like, what is the infrastructure that's available. Naveen, you talked about this, just like the weather map, but what if you had access to who has connectivity so that if you need to deploy information like malaria nets, like sending out medical information, you have exact information as to where are people and who can you reach. So I do believe that there is a gap. So when you asked me for a word, Alice, and I chose the word access is a challenge, but technology could be the bridge. And I believe that we could work together to figure out how to make this happen.
Geralyn, I'd like you to add your thoughts.
Thank you. First off, I want to say that I am humbled and honored to be here today. It's incredible. As a technologist, what strikes me as very interesting about this
Geralyn, just speak a little closer to the microphone so we all hear what
Sorry
you have to say.
about that. What strikes me as interesting about this conversation, when I was hearing all the concerns about data collection at the edge, or about the accuracy of the data, or how quickly we can, what we call, ingest the data, I'm sitting thinking to myself, these are all problems that are relatively well-scoped, solvable problems today. So my high-level takeaway is, why haven't we had this conversation earlier, right? I find it extremely encouraging. I chose the word social engineering for a slightly different reason. I actually think when you look at the pace of innovation, it's a curve that probably looks something like this, right? A straight line. If I look at the pace of how we're innovating in terms of policy and governance, it's a much flatter line, and that is the area where I'm really concerned. How are we going to, as a collective global group, make sure that the right policy is in place so that the data is treated with dignity, it's secure, and all of the things that need to happen for us to realize this vision, which is an interesting juxtaposition, because I'm sure that that is some of the same concerns that everyone here lives and breathes daily.
Dr. Pate, I'd like your thoughts on what Peter had said as well, this idea that the data that we have may come too late. How useful is it from your position at the World Bank? Do you find that to be a constant challenge?
Thank you. I think I will go beyond my 3-4 months experience at the bank to really respond to what he said. In the context of a large public health program, like polio, for instance, many years ago in Nigeria, we realized that we get data 3 months old, and as a decision maker, how do you use that to actually change the course of the action that you're going to do the next day? So I agree with Peter on that it's too late, and we have to have, it needs to be almost instantaneous. But let me say, in the context of the Health for All and what we've done this week in New York, going forward, we know that resources are not enough, and there aren't going to be significantly more coming out of what countries are spending, no matter how we push to mobilize additional resources. We need to do that. But we can use precision public health to improve the efficiency of the resources that we are deploying, both in terms of policies, programs, and management of implementation, but also on the service delivery side. I think is very key. And the last point, which I think was not mentioned, I think we need to be mindful of the holes where we really don't have information. There are millions of people that are really not connected. They go through life not registered at birth, not having any contact in a way that they get registered through a formal system, and so they don't get counted. That's one. But also whole huge swaths where the data infrastructure isn't there to even capture them. Either the mobile data, so those are in the fringes of society, and that those segments oftentimes are the ones that we need to reach the most to make the Health for All agenda real. So I agree with Peter that we need precise data, we need more data, we need to learn from the data, we need it quicker for decision makers, but acknowledge this other dimension and to be mindful how we configure the conversation around data.
Seth, I'd like you to jump in here and take us a little, give it a little bit of a positive spin. Have you seen, programs in your experience at Gavi that have been able to bridge that divide? Been able to really address that issue of being timely or starting to, new programs, initiatives that you are seeing, come up that might still be in testing, but, that bode well for being able to address the concerns Peter raised.
So, Alice, I will answer that question in a second, but I want to be a little bit provocative and maybe the odd man out here. I said decision-making, and you heard Peter led from timely data to decision-making, and I fully agree, and everybody who knows me here knows I'm a data freak. But what we need also is a mindset change. And we need to have people who appreciate data for decision-making. And the reason I say that, it's not that we're without data, and it's not that we're without even data that isn't complete that can be used for decision-making, but we're often paralyzed, and we don't use the information we have. And so what we have to be careful of is to say, well, it's a technological solution, we'll have instantaneous data, now everybody will use it for decision-making. That's not the case. So let me give you some examples of minor changes where data has made different, but it's been the culture side as well. So in Pakistan, there was a big problem, with people not showing up, ghost workers and others. One of the chief ministers of Punjab, the largest state, worked with some partners to put together a very similar thing, gave people cell phones, and they had to report for duty, they had to mark when they were there or not, and they did some spot checks. And all he had to do was fire a couple of people, and everything changed. There was a 17% increase in coverage in that area because all of a sudden clinics were open. People came and there was somebody there, and it changed the whole dynamic of what was happening. Now, that's the power of data, but you also had to have the mindset of somebody to use the data to make a change. Another example is crowdsourcing. We don't just care about diseases or data. We want to know the quality. Are people having good experiences? This is something we can do today. The question is, will it be acted on? Because if it is acted on, if people are empowered to say, hey, I went to the clinic and it was out of vaccines, that will then allow an intervention that can change that and fix it, but we have to make sure it really happens, because otherwise people will just say, well, they were out of vaccines like they were the rest of the time, so I'm not even going to bother to report it. So this mindset change is going to be critical along with the power of the tools we have.
Peter, along those same lines, have you seen changes, either big or small, that could make a difference in addressing the concern that you raised about being more timely with our data and making better use of it?
Yeah, and I feel guilty for setting people off on a sort of negative time. I don't think we should be negative at all.
We're here to learn. So
the very fact that we're having this conversation, and thank you to Rockefeller and UNICEF, is a great thing. I mean, the very fact that this sort of cast of characters and this size of audience is really focused on this is a really, really positive thing. And I think there is actually a lot of innovation going on and a lot of really creative partnerships. We have a bunch of different partnerships working on technology issues. There's a massive amount of investment going into health management information systems, into national accounting systems, into better supply chain systems across many of the poorest parts of the world. But I would say, I think Seth's point about mindset is a good one, which is that the mindset that one takes rapid decisions in a real-time way on the basis of data, even if some of the trade-offs you're making are quite uncomfortable, is, let us say, not universally held in the global health space. So that would be one issue. The other issue, I think, almost more than the technology, there is a lack of capability in many places of knowing what to do with the data. I reckon statistics and the ability to interpret data and make useful conclusions from it is one of the most underrated sets of skills. And we simply need more people who are able to do that and derive useful conclusions. But as I say, there is a huge amount going on. There is a real recognition that this is critical. And I would build also on Mohammed's point about efficiency. If you don't know what's working well and what isn't, or you only discover it a year later, you miss a huge opportunity to scale up what works and stop doing what doesn't. And that's a really basic bit of, I don't know, good management.
Dr. Aceng, you raised that very critical issue that, if we wait, if we don't have data that's timely, lives are at stake. Are there programs or initiatives or ideas that you have for seeing how we can either include more people, as Peter was saying, who are educated in statistics, who can understand and interpret data, whether it's more people who are in the field gathering data? What do you see as the biggest priority for you in Uganda?
Well, I think the most important data for us to collect is data that is collected from the communities, by the communities, and filtered through the system for use. That is very important data. For example, we have a system called Family Connect that we use in Uganda, where the village health teams collect information from pregnant women, but also it enables the women to receive life cycle-based messages and reminders and educative messages for them and their children. And it reminds them about when they need to go for antenatal care, when it is time for them to take their children for immunization, and it also gives us information about children that have been immunized and women who are attending antenatal care, and also women who need immediate action, those who are in deep trouble. This is a good system that needs to be rolled out to the entire country for us to be able to support those women, but also track on those who fall out of the system and end up maybe not immunizing their children or end up dead. There is also important information to collect from the system based on the family lifestyles that will help you to track families and know who is sick and who is not sick and who needs help, but also to be able to track where you have potential outbreaks that are likely to occur. And if this can be followed up on a dashboard, it even makes it much easier. This is what we do for many of the diseases that have potential outbreaks, like Ebola, like malaria, and many others. We are able to follow them on a dashboard. That is why you hear Uganda reporting real quick, because of such information systems.
Well, it sounds like it is the Facebook version, right, of, of public health there. Hema, I wanted to talk to you about the blood donation program that Facebook started. It seems like a very good framework for starting to think about how we might reach people in the community, more people in the community, as Dr. Aceng is saying, in a way that is really real to them, because that's what's important too, I think, in many of these cases, is not making the health or the connection seem odd or uncomfortable, or even sometimes frightening. How can a company like Facebook capitalize on the network that it's created to really make a difference in health outcomes and to perhaps build on a program like the one in Uganda?
Thanks, Alice. For some of you in the health space, you'll recognize this. The Latin root for the word blood is Hema as well. So when I work on blood donations, it truly rings fairly close to me. What's the problem we're trying to solve with blood donations? Every 2 seconds here in the US, somebody needs blood. This is true worldwide. Blood is such a vital component of the health infrastructure, regardless of whichever country that you're in. And 1 to 3% of the population need to donate blood voluntarily to keep a safe supply of blood in the system. Does this happen? No, not always, right? Countries like India, Bangladesh, Pakistan, people rely on their own personal networks. I relied on my friends and family when my dad, who was diagnosed with cancer, needed platelets, and I had to find my own family and friends to come in and figure out how to solve this. It's very morbid, but I do call it the BYOB system, bring your own blood. Now, is it any different in a country like US? Of course, yes. A lot more sophistication, a lot more technology. But even here, there are shortages. There are seasonal shortages. Summer is, school is out, you don't have enough donors in. So where does Facebook come in? There are 3 places that we think of this program that Alice referred to. Fundamentally, there's an awareness issue. So how do we get to people to create that behavior change to engage in the system? How do you put your hand up and say, I want to be interested in donating blood? The second piece to this is information. How do we create the right set of information? Where are the blood banks? How do I get to them? What are the opening hours? Who can donate blood? Am I eligible? I travel to India. Can I donate blood? So many questions. The second piece is information, and we can bring that to you in your pocket. The third piece, and I say this with a smile, people are really kind and very, very helpful. You know what kills altruism? Bad traffic. Hands down. It is incredibly hard for people to take time and figure out when is it convenient for them to donate blood. We can bring that convenience to you by telling you that, look, here is a blood bank right next to you where you can go, and maybe it's closer to your work, maybe it's closer to your home. We can bring that convenience, and along with the convenience, we can bring your friends, because you can actually ping your friend and make it easy to share, to find the courage if you've never donated, to go inspire somebody if you have. I'll come back to this. The root of the problem here is it's a behavior change in public health. It's an important part of the health infrastructure. The only way that Facebook can actually make this successful is by working with partners, be it American Red Cross and Vitalant here in US, or if it is National Blood Transfusion Council in India. That's who we work with and get the blood banks onto the platform, give them the tools and the training, and then we connect them to the donors, because the Facebook family of apps are ubiquitous. It is one example of how we can bring technology closer to bridging a health problem. And I land on this, Alice. I am a real optimist. I do believe that technology can play an unprecedented role in bridging the access to the people. I call it, I'm an optimist, because even my blood type is B positive.
Seth, you have a comment?
What?
You have a comment?
Oh, I was sorry, I was going to change the topic slightly, but
Okay,
is that
go
okay?
ahead.
Yeah. We're driving. On the blood bank point of view, what's interesting is Rwanda is delivering blood by drone in real time, and they've gotten wastage completely out of the way using technology. You can get it in 20 minutes anywhere in the country. So
Amazing.
These are really cool technologies. But I wanted to jump into the vaccine space, as you would expect me to, Alice. And what's interesting is vaccines are the most widely distributed of all health interventions. Today, 90% of people have a first dose of a DPT-1 containing vaccine. Of course, if you're a mathematician, that tells you that 10% don't, and they're not equally distributed. So the challenge is, how do we get that health system out to that last mile? And that last mile is critical. If you don't have vaccines, you don't have any health interventions. And if you don't have any health interventions, if you get sick, you're more likely to die. That's where epidemics are going to occur. So this is a data problem, and it's a problem of getting people to focus in on those areas, but there's usually a reason. why they're being missed.
I was going to say, it's not just data, it's a bigger problem, right?
Right, so there are political reasons, but that's why you need a culture of data and you need to have an iterative process of looking for those groups. And it used to be the hinterlands. It used to be that tukul that was as far away as it could be, but it's not that anymore. Now it's urban slums. It's, refugees or displaced people. It's people who have moved because of climate change issues. And because of that, we have got to have new tools that allow us to track them in real time. And if we can do that, we can really get to universality. And that's what builds, we'll be talking this week about universal health coverage, extending that out, because vaccines don't deliver themselves. There's a female health worker, there's a supply chain, and that will make the difference for other interventions.
But in looking at those other barriers too, especially in particular to vaccines most recently, the cultural, political barriers and obstacles there, couldn't data help there too if there were better dissemination and education about the effectiveness of vaccines, what they can do, and breaking down some of the myths and misperceptions?
Of course, that's absolutely critical. And sitting here next to my social media colleagues, one of the issues we need is we need a world where, one, intentional misinformation is not there, but that's not enough. When a woman goes on the platform because she's worried, she has a question, we need that woman to be steered to a place with reliable information that's appropriate to that person. And that helps a lot. But it's not enough then. We need to get the religious leader, the community leader, we need to get everybody informed, and that's, again, where technology can be very helpful.
And Geralyn, your word was social engineering, and it seems like this is exactly what you were talking about. Talk a little bit about how AI can really play a role in addressing global health challenges when we normally think of AI right now as, the very high-tech, very restricted use in, for example, being smarter about reading images, on mammograms. And that's our perception, I think, of where AI is showing the most effectiveness. Think ahead, blue sky it a bit. Where do you see AI making the most impact in addressing some of these challenges in global health?
Right, and I want to echo kind of the behavioral challenges as well. When you step back and you look like 10 years out in the future, it's really going to require a mind shift. You can envision a world where there's not a lack of data, rather we're awash in data. And it's a different mind shift to figure out how we're going to make sense out of that data, what data is relevant, what data is not relevant. So I think we have to start shifting our frame of reference and how we think about things to prepare for that world. I also think it's not just about data, anybody's data, anywhere. It's really around responsible use of AI. It's about trusted places, secure places, compliant places to store this data. It's about the dignity of this data because this data is information about human beings. It's very personal health information. So these are all some of the challenges that I think you're going to see in the next 5 to 10 years, and which is why I chose social engineering, because these aren't necessarily technology challenges around bits and bytes flowing over the wire.
And Dr. Pate, when we think about addressing how data can make an impact on health outcomes, there's various aspects of it. There's financial, there's political, there's technology, there's infrastructure. Address what, in your view, are the largest financial challenges to making real impacts on health using data. We're at a situation now where we almost have too much data, as Geralyn was saying, and not enough people to interpret it. And even if we have the people to interpret it, we may not interpret it in the correct way, in the most optimal way. How do you make use of that data to make the smartest decisions about, which programs to support and, what makes the most sense for having the most impact in health outcomes?
So I'll give 2 examples. One is from more policy and programmatic or structural level decision making. It's a tool that you can be able to look at the fiscal space of a particular country or subnational locality relative to the minimum service package. Many countries have these minimum service packages that have been prepared and have been costed. But the resources to finance them falling short in many areas. And while we continue to strive to improve that, we need to also look at how can we optimize, given the resources available, the human resources and the infrastructure. So that is where you can combine data streams to make choices that can get you further with relatively constrained sets of resources, both in human resources, infrastructure, as well as money. That's a key element. Now, the other element that I think is going to be valuable is probably not going to be limited by financing particularly. It's more on understanding networks and how that shapes human behavior on the demand side, whether it's for vaccination or whether for non-communicable diseases or among adolescents, how to use data to actually drive those behavioral changes that we need. And those are add-ons, perhaps, that I think we could look into. For the Global Financing Facility in particular, given the platforms that we have at the country level with Gavi, with Global Fund, with other international financing institutions, but around country investment cases and their own budgets, there's real scope to seed innovative ideas to see how they solve local problems and how those can be taken to scale if we work collaboratively, particularly coming out of the events of this week in New York. So I think there's a good prospect going forward that we can learn as we go, but build on that platform that we have as Global Financing Facility that are owned by governments but supported by all of us to help move this agenda forward.
And I want to turn back now to the word that I asked each of you to come up with, describing how you see the challenges, the biggest challenges you see in making data work for health. And tell me just very briefly about how optimistic you are, in addressing those hurdles, and that we'll be able to address them and overcome them.
I could have just used my be positive right now. I am really very optimistic, and I think again
for
as
access, right? That we'll be able to increase access.
For the word access, and I think as some of the tech companies sitting here alongside this amazingly distinguished panel, there are ways that we could think about this: communication, community, connections. How do we bring these together to build that bridge to access? I'm really very positive about this.
I'm an incredible optimist, and of course I'm a technology and data freak, as I said before. So I think
but also a realist.
but I think what's interesting, I mean, if I look at it from the narrow sense of Gavi, we spend $27 for each child to give them all the WHO recommended vaccine. If that was $29 or $30 and we could follow them and see if they missed doses or there was stockouts, it would probably be cost savings. So even the money should not be the barrier here. The challenge is going to be we know that 50 years from now, everything will be done this way. We can do it now. We have the tools, with technologies. We just have to drive it forward. And that's why I'm excited about this initiative, because it gives us an opportunity to drive it forward.
Okay. Geralyn?
Since we're disclosing, I'm a cautious optimist. And the reason why I choose those words is because these are difficult problems. I'm encouraged by the fact that we're all together here today having this dialogue, because I think dialogue and the foundation of trust is how we start down this path. But with that, I think that the future in healthcare, I think of the phrase, necessity is the mother of invention. I don't think we have a choice here. And so I would rely on my colleagues, my esteemed colleagues, to say we need to do this. So we need to put aside our differences in terms of the way that we frame the problem and think about the problem and come together to solve these issues.
Dr. Pate?
I think precision public health will happen. Ultimately, it's inevitable given what we know in this space across different sectors and also in our sector. Question is, how do we shape it to solve the problems that we need for the people that we need to reach in order to achieve health for all? I think I'm optimistic, and I'm really glad that Rockefeller and others are really taking a huge leadership role in this direction. Thank you.
Dr. Chang?
Well, I am very optimistic, and what I would want to say is what we need as countries, especially in Africa, we need access, we need availability, we need skills, we need policies and legislation and data governance so that all these things can move forward. Africa is ready, and I am excited to have Rockefeller and UNICEF support Uganda to be good pilot countries to show that it really works. And we are determined to show that it works. Thank you.
Thank you, and I want to thank all of our panelists. This should be a starting point, I hope, for further discussion. So thank you very much. And now it's my pleasure to invite back Dr. Naveen Rao, who will introduce the next speaker.
Yeah, so I thank you, panelists. Really great. I appreciate that. Thank you. Alice, really appreciate your guiding us. It was wonderful. Thank you. While we're waiting for the panelists to leave, if you notice there, it's hashtag Data Saves Lives. Apparently, hashtag Data Saves Lives is trending #1 in New York City on Twitter right now. And we have had over 50,000 tuning on online, watching this online. So, thank you everyone who's helping us create a movement. And at this point, though, I have bad news and I have good news. Bad news is Dr. Tedros is stuck at the United Nations. He just sent a text saying he wished he was here, and he apologizes, but you can understand. He is in some crisis at the United Nations. But the good news is we have Dr. Samira Asma here with us, Assistant General, Director General at WHO, and she has kindly consented to speak on Tedros' behalf, but also is eminently qualified to speak on WHO's behalf. She leads the data analytics section at WHO, and Samira, really thank you for stepping in.
Good evening. And I oversee the division, a new division, which is indeed a transformational shift that Dr. Tedros has spearheaded. It is the Division on Data Analytics and Delivery for Impact. I just want to say what a terrific announcement to propel the forward-looking possibilities for precision public health. And a thank you to a fantastic panel. And I think it has given us a lot of ideas for future collaborations. So I will now want to share with you what Dr. Tedros wanted to share tonight. So I'm going to read his speech. Excellencies, distinguished guests, dear colleagues and friends. First, I offer my thanks to the Rockefeller Foundation and UNICEF for hosting this event. I think you will all agree that this has been a momentous week for global health. On Monday, member states endorsed the most comprehensive international agreement in history. And yesterday, Tuesday, 12 multilateral agencies came together to launch the Global Action Plan for Healthy Lives and Well-being, a bold initiative to leverage our collective strengths to accelerate progress towards the health-related SDGs. And together, we have agreed to accelerate progress around 7 key programmatic areas. One of them is data and digital health. Until now, there has been insufficient coordination among global health and development agencies on data and digital systems. But reliable, timely, and actionable data is essential to achieving universal health coverage and other health targets. The Global Monitoring Report on Universal Health Coverage that was published on Monday shows that on an average, only 40% of data can be reported on UHC indicators, and I think we have a long way to go. And not a single country has all the data that is needed to track UHC in an effective way. We cannot achieve our goals unless we know who is left behind and why. Too many people are not counted and not reached. Traditionally, we have always looked at familiar measures like gender, income, and geography. And these are important measures, but they are indeed insufficient. We also need to consider other reasons people are left behind, like migration or internal displacement, conflict, marginalization, and discrimination. Disaggregated data is vital for painting a more accurate picture of where services are needed and where gaps must be closed. Examining only national averages misses inequalities within populations and across different subgroups. And since health inequalities occur everywhere, and we have heard that, we all stand to benefit from strengthening national, subnational data and health information systems that will also enable us to monitor inequalities effectively. Precision public health that draws on the power of big data, predictive analytics, and granular and timely surveillance that you showed by 5 kilometer grid is essential for delivering the right interventions to the right people at the right time. Digital technologies combined with genetic and other data could help identify which populations are at risk. Dear colleagues and friends, we have never had a greater need for disaggregated data, and we have never had better tools for generating and analyzing it. WHO is committed to working alongside with partners and with countries to strengthen health information systems to generate better data and move us all closer to a healthier, safer, and fairer world. Thank you so very much.
So they say the measure of a good meeting is if it ends on time. I will now invite you all to join us for refreshments in the foyer. But before we do that, I just have 2 words that summarizes what I think we've seen here today is honest conversations and unconventional partners. We at Rockefeller are committed. The question is, are you with us? Thank you.